Philip said he's joining, so he should be
Okay.
getting on momentarily.
Awesome.
So that might be what we need. I'm thinking maybe.
Yeah.
Okay.
Thank you.
Good afternoon. This is Kelly Sheets with Department for Medicaid Services. I believe I just let Jill in through the waiting
Oh.
room.
Okay.
Somebody named Jill. That was all that was on their name was just Jill.
Might be a different one. Let me check.
Okay. I have 12:57, so we can definitely give it just a few minutes.
Okay. Yeah, we're trying to get Philip on the call with us for sure a quorum.
Philip is joining now.
Okay, awesome. If you don't care, Kelly, we can get started with the
Yeah, that's fine.
just passing a few things here with the minutes and that type of thing. So, but that'll give still time for people to get on there just that need to watch it for stakeholders or what have you. But anyway, welcome everybody. I have 11:59 my time, 12:59 your time. My name is Ron Poole. I know we have a quorum with Philip on the line, Paula, myself, and Rosemary. I don't see Meredith. Matt Carrico said he couldn't make it. Jill McCormick said she could not make it. But anyway, that should be enough for a quorum.
Ron, I apologize for interrupting, but Meredith is logging in now.
Oh, okay. Awesome. Okay, so we got it. So I sent out the minutes whenever Kelly or Aaron sent them to me. So if anybody has anything to change on that, if not, I'll entertain a motion to approve the minutes.
Motion.
Motion by Philip,
Second.
second by Rosemary. Any further discussion? All those in favor say aye.
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 Any opposed? Okay, let's go ahead and move into old business. This may be taken care of by the House Bill 3, which we're going to discuss under new business, but basically what I've talked to Trip Logan about, which Drug Topics did a story on him and his community health workers that are also his pharmacy technicians. Obviously getting medications to the patients, especially in special needs people, such as the homeless, such as in mental health cases where you help them be compliant. I've got a unique situation here in Central City because we have a mental health clinic right next door to us now that after we moved, and they house 100 on any given day, they house 100 people around Central City and all the different rentals that they have to help them get through their different programs, whether it's mental health program or whether it's addiction program. Name of their place is True North. So again, that's something that we help coordinate to make sure somebody stays compliant. We also have, some aid and there's several services that help us in coordinating people getting to and from doctor's appointments or their counseling appointments. And certainly, I don't think anybody's immune to this. All the issues that come with homeless, being able to find them, keep track of them, make sure they stay compliant, make sure they keep their doctor's appointments, make sure that they do have an avenue in bad weather or anything else in order for us to reach them. And certainly communicating with the shelters, social services, social workers, uh, and trying to obtain more permanent housing for them. I know that's things that we assist with currently. What'd you say? Okay. Also assisting and communicating with the food pantries, utility companies, and other nonprofit assistant charities on obtaining funds to keep someone's electric or keep someone's utilities on. All of that fits into um, what we currently try to do, and certainly could be under the realm of a community health worker. But I do feel that House Bill 3 does address the community health workers also. Um, so in lining up with that, we did get a response on the long-acting antipsychotic medications, but I just want to point out that you can definitely save money by utilizing pharmacists because every time they're going to a doctor's appointment, it's as high as $75 for a community health center to see these patients on the long-acting um, medications such as the Abilify Maintena or Aristida, Zyprexa, Invega, and Risperdal Consta. All of those um, need us. I know with us working with the facility next door, we try to be invaluable to them. That we're used to tracking people down on MedSync, so it just kind of goes hand in hand that we can keep up with these individuals and make sure that they stay compliant on their medicines. And then we also, in talking about just getting injections to help out people on B12 or Depo-Provera or any type of injection, to be able to, pay an admin fee, which would be a whole lot cheaper than paying a doctor's visit plus an admin fee.
Go,
And certainly
go.
the doctors are also, billing, if they're providing the service there, a lot of times they may even provide the drug and also bill with that too. But to me, that there's definitely a savings there. And certainly with people who are used to tracking people down, it makes a big difference. Does anybody else have comments on the long acting or any kind of uh, administration help to keep people compliant? I wanted to see if Rosemary and Meredith are in the same ballpark as me on that they're helping to keep people compliant and calling them ahead of time, 5 days ahead of time, to make sure that we got some kind of contact with them.
Yeah, absolutely. I think the amount of follow-up we do is extensive, and to your point that's been said is, these type of medications being injectable increase adherence, which saves all kinds of money in the long run. So,
Oh yeah. And I know of several, well, I just get feedback from True North over here that when they're going to their regular family physician, if they're not managed by the practitioners here and they're going to the regular, they're less compliant because they won't go and sit for, an hour and a half, 2 hours to be able to see the doctor to get an injection. So again, we're assisting and just trying to let that physician know that, hey, if you're just talking about injecting, why don't you let us help out with that, and we'll keep them compliant, and we'll let you know if we cannot get in touch with them. And that seems to work a lot better in our situation.
Yeah, I agree.
I want
Okay.
to just second what you both have said. Not just with long-acting antipsychotics, but with a wide range. The pharmacists do make care more efficient, make patients more compliant. We have a transitions of care clinic where patients leaving the hospital on 16 different meds, they first make an appointment with a pharmacist before they see the provider, because there's so much untangling that needs to happen. Because there's duplicate therapy, there's inappropriate therapy, things that are starting and stopping, and any sort of that service, I would say, does a lot to reduce the cost of care to the larger system. And coverage for those types of services should be supported. And I am excited to see House Bill 3 being introduced, because I think that will help with a lot of this.
And Philip, if you could elaborate on this, do you all, since you all cover, I mean, you all draw from the entire state and maybe even outside the state, I don't know, but do you all have other pharmacy partners in certain parts of the state that just help assist you on that transitions of care? Because I know with myself, we have somebody we have a health system that does beds to meds that's fairly close to us. And it seems like it hurts more than it helps. And if they had a partner out there that the patient could go to first, and a contact back at the hospital, because what's the number one thing that happens? Oh, it's not on the formulary. Then, like you said, just going through our regular drug utilization review and making sure there's no duplications, or making sure this patient can tolerate the medicines, or maybe, because we all know when you're being discharged from the hospital, you're going to say yes to everything so you can get out of there. And then the stopgap is when they come to us and they're like, well, here's all my stuff. I really wasn't paying attention, as I just was trying to get home.
Yeah, that's a great point. And so I'm feeling that, yeah, meds to beds is a big piece. We found that patients that don't participate in meds to beds had a 40% likelihood of being readmitted within 30 days.
Wow.
So meds to beds adherence is pretty high. In regards to those patients that are outliers because they're at high risk of being readmitted, or different situations, we have a group of population health that monitors them, and then they triage that group for placement. More often than not, that group does not have a primary care home, and they're trying to establish one. I'm happy to talk with you offline about partnerships for area partners, because we don't necessarily have hubs outside of Lexington for doing these kinds of things, but definitely open to talking about that.
Okay. And I'm just curious, is it your pharmacist that really manage that transition of care program, and also kind of, I know part of the job is to rate each patient as a risk for readmission. And I do know that there's a hospital system that I've listened to at conferences from Iowa, that if somebody is on mail order, they automatically put them on high risk because they don't have somebody that's really going to manage their medicine. But go
Yeah, we
ahead.
do have pharmacists physically in the clinics that will meet with the patient before the provider. We'll ask them to bring their medications. Doing something over the phone alone is not enough, we found, because they'll say, I'm taking lisinopril 20. Well, they got a bottle of the 20s, and they have a bottle of the 10s as well that's dosed to 20. And so they'll make assumptions that you understand what they're holding. So it's important that we have that physical encounter as well. It's a combination of doing some of this virtually and some of it in person. I will say, if I could, the requests I have for more pharmacist coverage, particularly in the primary care space, is increasing because of the complexity of these therapies for patients. I think providers are becoming more heavily reliant on pharmacists to be part of that care model if they're not already part of it today. They want that. Most providers have a handful of medications they're comfortable and it's in their wheelhouse. When you start crossing into specialist care along with primary care, it can get very confusing. It gets more confusing if the patient's going to 2 or 3 different pharmacies trying to chase coupons down to save money. That just
Right.
makes it more confusing.
Yeah. Thanks for all your answers there. I really appreciate it.
Hey, Ron, I think Ben has his hand up.
Okay, go ahead, Ben.
Thanks, Sean. So you said that you got a response back on this, and maybe I misunderstood that. What response was provided?
Let me see here. Hopefully, if I've got it pulled up here, let me see if I can find it real quick to say exactly what was said to me.
Okay. And I think another point that we try to make is like, in addition to, yes, the potential cost saving of, office visits and whatnot, like at the end of the day, we just gotta meet patients where they are, and pharmacists are able and trained to provide these services. And, some patients may be more comfortable going to their physician's office or provider's office to get these injections, but certainly we know patients that would feel more comfortable getting that done at their pharmacy. So it's, the basic principle being pharmacists are able to provide this service, and we need to be treated like other providers in that way.
Okay, Ben, on,
Yeah.
let's see. Okay. It was the second response on this one. The first one was a response on community health workers. A motion passed to accept pharmacists as providers. And then the response was Medicaid will take this recommendation under advisement. Additional research will be necessary to make a determination. Obviously, House Bill 3 addresses a lot of those issues. Then the other recommendation, motion passed to pay pharmacists for administration fee on the long-acting antipsychotic medications. DMS response, Medicaid will need to evaluate the financial impact of paying pharmacists an administration fee for antipsychotics. Pharmacies currently receive a dispense fee for dispensing the medication. Medicaid members are not subject to fees or copays for administering vaccines. If providers are charging Medicaid members for administration of vaccines, DMS needs to be made aware of the specific providers. And again, I don't believe that's happening, but they just put that in there, and they put it, anonymous information can be provided through the Medicaid fraud and abuse hotline. So does that answer your question?
It does. I mean, I think it really helps make the case that it's necessary. I mean, the
Right.
administration fee for immunizations, Medicaid is aware that needs to be paid at a higher rate than the standard dispensing fee. So I'm not really, that's where I get a little bit confused on what's the difference between an Abilify injection and an immunization, and arguably the Abilify, some of these injections are more complex than an immunization, because you have to prepare them, mix them. It's a different injection site. You might have to have different setups to do it. So I would argue that for having done these, you probably need to be reimbursed more for these shots than even for an immunization.
And the good point there, Ben, is that it actually will save money versus going for them to go to the physician's office every single, especially in a community health center. So, and that's just in comparison. I'm not poo-pooing any other, just like you said, they may prefer to go to the doctor's office or the ARMP's office, but, it's just a matter of it can save money and it can increase their touch points because we have the ability to contact them and communicate with them a lot more than a physician's office can. So anyway, you're depending on the statistics, a patient will see them 13 to 18 times a year versus 3 to 4 times in a practitioner's office. So depending on what study you look at. Okay, can we go lower in the? Okay. On the dual eligible Anthem exiting marketplace, if Fatima, if you can comment on this, because it's one that Anthem is exiting the market, but it's another thing as to what the default switch is to, how was that decided? Because that's actually why Matt Carrico is not on the call today, because his insurance firm is having to contact all these people and switch to something else besides WellCare, since he does, um, or just have these interventions with the patients to help them decide what's best for them.
So, if I'm understanding the issue correctly here, and I apologize, I didn't have a chance to clarify this with you before the meeting, but is the issue that they're not being reassigned to another managed care plan, or is it something else with Anthem leaving the marketplace? They should have been reassigned to another MCO, and members do have the right to change their MCO.
Okay.
Well-
Well, I apologize because I got the wrong information then, because I was told by a local insurance agency here that deals with a lot of, unrelated to me, they're separate, that the default was going to be if they did nothing, if they contacted nobody, they would be referred to WellCare. If that's incorrect, then I apologize for that. What is, if somebody does not take the time to look at, switching and what's going to be the best for them, is there a default or is it on a rotation basis?
Dr. Emery, if I may address.
Go ahead. Angie.
Hi, this is Angie Parker. I'm with the Department for Medicaid Services. And I think we're looking at two issues here. If I see regarding new business, dual eligible Anthem exiting marketplace, correct? Is that what we're looking at? So there's two issues. There's Anthem, the Anthem leaving Medicaid in general, not because dual eligible is Medicaid, but it's a different type of plan.
Right.
So Anthem, regular Medicaid, the membership of Anthem was distributed between United and Humana.
Okay.
They had that opportunity to change to another MCO if they wanted to. And the reason those two MCOs were chosen because they had the least amount of membership. So if one is assigned to Humana, they could change if they wanted to. There was always that option. The dual eligible Anthem exists exiting marketplace because Anthem, regular Anthem Medicaid, was leaving. This also affected the dual eligible Anthem members. But the process is not the same because a dual eligible is basically a Medicare Advantage plan. So the dual eligibles should be getting, if they haven't already, received a letter from Anthem telling them the process on what to do and how to do it as far as choosing another Medicare Advantage plan.
Okay. Well, I got the wrong information. I apologize for if I steered people down the wrong road there, because I was told just by this insurance agent, and maybe that's all he offers. I don't know. But thank you for cleaning that up. Because again, I do kind of have a misleading. So, Anthem is just exiting, period. So if I'm understanding correctly, not only are these dual eligible Anthem plans obviously going to change, also the Anthem part, just regular Part D is going to change also. Is that correct?
Oh, I don't know about the Medicare part of it. All I know is the dual eligible Medicare Advantage plans. We, because our requirement in order for them to, because a dual eligible Medicare is their primary carrier. Medicaid is a secondary that we would help pay for copays or those types of things that Medicare doesn't. So, I don't know about Medicare D. I don't know about the pharmacy part. I think it just depends on whether or not they're with a Medicare Advantage plan. And that Medicare Advantage plan covers pharmacy.
Okay.
If they don't choose one, they may be in the traditional Medicaid. And that could be a different, how the Medicare Part D works. I'm not real, I do not know that.
Well, let me explain something to you that is a problem in a pharmacy. All right, every year, we have quite a bit of new plans that come out. So what do you think all of my technicians and pharmacists do? They'll find a bin number and they'll find a PCN that matches, and it could be called Ron's Insurance
Mhm.
in our system. And they'll just go ahead and pull that bin PCN up and put that group number in and get the paid claim, and everything's wonderful as far as my staff is concerned. But the names are deceiving. So that's my problem right now. I have quite a bit of people on some, like, for instance, Anthem MetaBlue. Well, some of them are on there because they are dual eligible, and some are just regular Medicare Part D. So that's not your all's fault. That's a pharmacy's fault. I wish that I could go through and enter all new plans every year of every single plan, because they call them different names every year. They'll switch up on the numbers. That's not your all's fault. But I just wanted you to get a little, I guess, education on what our frustration is. So my question coming is there a portal somewhere that allows us to put in someone's ID, and whether it's their Medicaid ID or even Medicare ID, that would allow us to see if they are dual eligible or not?
Let me see if someone from our policy division is on here. They would probably, or eligibility. We may need to take that back if they aren't. My assumption would be yes, but I don't want to say yay or nay at this point till I verify that.
And did I explain my situation?
Yeah, so you want to know if a Medicaid person has a dual
right,
eligible plan.
because when we set it up at the first of the year, when we enter everybody's new stuff, I mean, unfortunately, I don't, and I could, maybe Meredith and Rosemary are a little bit more organized than I am. Maybe they do mark the certain plans as dual eligible and it works out just fine. But in my world, they just pull up that bin number that's the same as, they just get the right bin PCN a group number and they bill it, and it could be called whatever. But that's our fault. I'm not saying that that's something you all need to fix. I just need a good resource to be able, because I've got 250 people with a bin PCN a group number that goes along with those dual eligible ones. But I know not all of them are dual eligible. So I need something to where I can easily put their information in and find out which ones are dual eligible, to where, they're going to need a reminder. And I know y'all mailed them out, hey, you need to be looking at these plans because your plan is going to stop February 28th. So anyway.
Well,
So,
and we can look to see from a Medicaid side of things if there is that through Kentucky Health Net. I don't know the answer to that. But because a dual eligible plan is a Medicare Advantage plan, the back of their card should be able to tell you how to check these things.
that's, that's the
But
problem.
to easily pull that up, I don't,
Yeah.
it would probably be a Medicare site.
Okay.
I'm actually, excuse me, this is Kelly Kitchen. I work on
Thank you.
policy. Kentucky Health Net does show if a member is dual eligible or if they are QMB. There is a place when you go into member eligibility, it will say, if it says Medicare savings and it has a Z, that means that they're QMB. If it has any other code other than a Z, like zebra, then that means that they are dual covered.
They are or are not dual covered.
They are dual covered. If there's
Okay.
any code listed other than a Z, so sometimes there'll be a D program code, or there's other excuse me, there's other program codes other than Z. There isn't actually a lot of members with QMB only. Many of the fee-for-service members are dual covered, but if you see a Z in the field, that means that they are QMB only. But if they do not have a Z, then they are dually covered.
Can you call off that website and the portal again, if you don't mind?
The portal, Kentucky Health Net portal is, and I apologize, it's going to take me just a moment here. It is www.kymmis.com. If you do not currently have access to the provider portal, you would have to request access.
Okay. And could you say that again? On my end, it interrupted you.
No, it's okay. I can put it in the chat. That'll probably
Okay.
make it easier.
Ron, this is
Okay.
Kelly. I did put it in the chat and I'll
Okay.
send it,
Oh.
I'll send it out in an
Okay.
email to the TAC members.
Okay. Thank you all very much. Thanks for your help on that.
You're welcome.
Ron,
Yes.
could I add?
Yes. You go right ahead.
With our 6 Jordan Drug pharmacies, we identified, we were in the same position you were with our Anthem, Medicare Advantage, DSNAP patients. And to try to identify those, we just had to run the BIN and PCN. And we ended up with over 500 patients. And what we had to do, we had to look up the Social Security number for each one of those patients. And then we went on to the website that Kelly was just talking about. And when you look for contract ID and it's H9525, that's the Anthem Medicare Advantage plan that is no longer. And then you're able to scroll down and see if the patient is dual eligible, if they're, and that's all on the website. But the
Okay.
key is just, getting down to, the patients and getting their Social Security number, because that's how you have to look them up. But
Okay.
it's a lengthy process, but it is doable.
Well, it's shorter than going into our software because I think you and I have the same software. My gosh, you have to go into the edit screen, then you have to click on eligibility, then you have to put in all their information. I mean, it takes 5 minutes within our software, and you're like, that's not an efficient way to look up 500 different people, or in my case, 250 different people. So that this should help us be efficient anyway, or as efficient as we can be. But thanks for letting me know that.
Yeah, I think that's helpful. Unless you all are different than me, the amount of actual physical cards that you ever see from patients is a pretty low percentage. So, and unfortunately, that's where a lot of that information is.
Okay. Okay. Next topic is House Bill 3. It's right now it's 5 pages long. It's just straightforward. It obviously couples up with House Bill 48 that was passed in 22. Does anybody, Fatima or anybody else have a comment on that? I think it's, I've got the explanation or the summary, which is on the but it's, it's pretty straightforward. And I didn't know if anybody had any comments on that. I just wanted to put it on there.
So from my perspective and from Medicaid's perspective, we're still reviewing it and happy to listen to any comments or feedback on this call.
Well, I know Rosemary and Ben are on a committee with you all, so I know we're well represented there, and you certainly have a resource there with them to, answer any questions or get any details worked out. So I just encourage the communication, and certainly you can get a hold of me, but I know with Ben representing KPHA and Rosemary representing KIPA, I know that they meet with you quite frequently. And certainly if there's anybody else, whether it's UK Med Center or National Association of Chain Drug Stores or whatever, anybody's welcome to help out with this, because I think it's going to be a paradigm shift in what pharmacists can, the interventions we can make and improve people's health, because it's all about outcomes. If we're not going to show the outcomes, positive outcomes, then we're not going to get paid for it. But I do believe that there's definitely going to be that, because we've already seen it with other states, and we've seen it with other programs such as chronic care management and a lot of different other things. So anybody else have any comments?
I'd like to say, I think this is a great opportunity for Medicaid to align with clinical practice, the pharmacy. We are far more accessible than physicians and APPs. Patients love telling us all about their medical histories and what their issues are, and we're very accessible. I think there's I think the industry has invested some, and when I say that, community pharmacies, chain stores, health systems, we've invested a good deal. But I think if Medicaid were, to have this offering, you would see an investment from the community pharmacists, from the hospital pharmacy groups to make this a very workable model. I think, when you're only, in many cases, only billed per an adjudication, you have all this time and energy you could be putting towards these patients. It's just not as much of an incentive. However, having the ability to bill for your clinical services, it might normalize and cause more investment from your community partners of Medicaid, to put more energy into this. And I think it's a step in the right direction. I think other states have done this, and I think this is a great opportunity for Kentucky.
Yeah, great comments.
So I know we've talked about this in the past. I just wanted to give, maybe I've done a little bit of research about other states' Medicaids and what they have done in this area as far as providing payment for services that outside of that dispensing service that we provide. So a lot of them do like health risk assessments. This can include statin use and adherence, cardiovascular endpoints like blood pressure control, decrease ER and hospitalizations, asthma, decrease rescue inhaler use, and opioid misuse and management, where they're decreasing morphine milligram equivalents, increasing naloxone dispensing. They've looked at schizophrenia populations, back to what we were talking about earlier, as far as converting those patients to those long-acting injectable medications that increase adherence and decrease cost. Diabetes population, looking at A1C, educating on A1C, reporting A1C, eye exams, blood pressure control. Outside of these assessments, they're closing immunization gaps. They're working with HIV adherence. So those are all these programs that other states are using pharmacies to provide. And specifically, I wanted to just throw out some specific examples about states that are doing it. North Carolina uses care planning and diabetes H1C reporting. Tennessee does care planning and looking at emergency department utilization. Texas is doing these assessments. They're doing stuff with behavioral health. They're doing blood pressure monitoring, A1C. Virginia, Kansas, Iowa, Florida, Georgia, all of those states have ongoing programs with their Medicaid department and their local pharmacy and providing these services that are outside of dispensing. So I just kind of wanted to put some specifics with what we've been talking about. And, you know, some of these programs already have the data to show how it's affecting not only utilization and adherence, but HEDIS scores for their Medicaid programs. So if you're ever interested in knowing more about how that reduction occurs and actual putting numbers to that, we can certainly provide that. But hopefully that shows you that, you know, it's not just some states. Like, here's some specific states that we know these programs are going on in.
And just to add to Meredith there, you know, this isn't a therapy, but it's point of care testing. I have turned down well over 1,000 TB skin tests because I can't get paid for them, and the facilities, their nursing home facilities, you know, they're not willing to forego, you know, their Medicare patients being able to pay for this. But no matter how I've tried, I can't get it paid for. And I have a medical director that orders the test. Of course, I administer the test, and I also do the reading 48 hours later. But that's another thing, because I could be so busy just doing that in Western Kentucky because facilities don't want to do it anymore, but they're required to do it. The health departments don't really offer to do it on a big scale like that needs to be, at least in my area. So Fatima, if there's, you know, obviously if I had a huge Medicaid population, but a lot of these people are just Medicare only, you know, I'd have been contacting you, you know, sooner about this, but I'm just struggling. But it just goes to show you there is a need out there for not only the clinical role, but some of the point of care testing too, that could really benefit and get a lot of people in compliance, that and even their vaccinations. That's really, we've really taken off on that too, with different nursing homes and different other group homes and therapies too. So anyway, thanks for your comments, Meredith. And I don't know if this bill will take until the next MAC meeting, but I thought it would probably be good if somebody, you know, made a motion and we seconded on, you know, we would really appreciate Kentucky Department of Medicaid Services to work with us and support this bill, and so we can work together. And so I just wanted to offer
Make that
that.
motion. I'll make that motion.
Okay. Paula made the
I'll
motion.
second it.
Seconded by Phil. Any further discussion? All those in favor say aye.
Aye.
Okay, thank you.
And Ron,
And-
just to
any
make sure that
opposed?
I get that correct, could you send me that in writing, please?
I sure will.
Thank you.
And just to let you know, Kelly, I do that after every meeting. I'll
Okay.
give a summary of everything. Okay.
Okay, great. Thank you.
Okay, move on down if you don't mind a little bit there. And then Paula asked me to put this on here. And Philip may comment on this too, but the first fill 84 days for Hep C patients. Paula, if you wouldn't mind to give us the details on this, please.
I think Jill also wanted to speak on this, but I'll go ahead and give my perspective. I had a provider reach out to me that they wanted to speak about this at P&T and was told they needed to contact DMS directly. So the provider reached out to me to get guidance. And this particular provider wanted to ask Medicaid to increase the 84 days on the initial dispense day one for those Hep C direct acting antivirals. And that's because these patients are transient in nature, and they have several that are in the residential recovery setting. So that was her recommendation. I believe I sent her letter, her resume, and her credentials to you, Fatima, for review. And I think Jill wanted to speak as well on behalf of this subject.
Okay. Is Jill on here?
I am Chairman Poole.
Okay, sorry.
Well, thank you for recognizing me to speak today. I just want to take a quick moment to express my gratitude to all the committee members in the work that you do here on the PTAC committee, lending your expertise. But in your day-to-day lives, I know this is volunteer work for you, but you demonstrate leadership, your persistent advocacy, and many of you, I've seen many over the years leading the pharmacy profession, and just appreciate the efforts that you've made to elevate our public health for our Commonwealth. So thank you.
Thanks, Jill.
So I come seeking support of the committee's approval in adjusting the maximum quantity limit day supply for hepatitis C DAAs in order to fulfill that curative intent course of treatment that can be dispensed as a single prescription fill with a quantity limit restriction at 84 days supply for the simplified HCV treatment criteria on the prior authorization approval form today. As informed members of Kentucky's Health and Needs and Welfare, I know you're well aware of the high incidence of hepatitis in our state, particularly Hep C. So I'll try to limit this to maybe 4 points. First, Kentucky does have a very high disease burden for hepatitis. Unfortunately, we have alternatively a low treatment rate. And according to the data I could obtain from the Kentucky Department of Public Health's viral hepatitis program, the most recent prevalence rates for new hepatitis C infections in Kentucky surpassed all those that were previously reported over a 10-year period from 2012 to 2022. In 2022, which is the most recent information that's available on the website publicly, new infections rose to 5.2 cases per 100,000 individuals, which is 5 times greater than the national average, and the highest Kentucky has had since 2012, which was reported at 5.1. This may represent an increase in improved engagement in testing, but it also demonstrates that we have a high prevalence rate and a need for curative medication treatment. 2, our state has committed to improve access to treatment for hepatitis C. KDPH did collaborate with key stakeholders to create our state's first ever comprehensive hepatitis C viral elimination plan back in 2022. And that viral hepatitis program goal was made publicly available and is to create a Commonwealth that's free of hepatitis C. Specifically, Objective 2.2 of the elimination plan is to improve the accessibility of quality care and increase the number of people with hepatitis C who receive and complete treatment, including those who use drugs and people in correctional settings. I think allowing dispensing of that full course of DAA therapy directly aligns with this Objective 2.2, and we know that 8 to 12 weeks of treatment results in more than a 95% cure rate. If I had this for all of the cancer patients that I'd ever seen, that's like a slam dunk, and we wouldn't withhold therapy. So that third point is that state Medicaid programs are expanding access to hepatitis C drug therapy elsewhere. So I went to look to see what other Medicaid programs were doing today in regards to the full dispense on full duration of therapy dispense on first fill. There are at least 5 state Medicaid programs that allow this full course of treatment of DAA therapy. Those are Colorado, New York, North Dakota, North Carolina, and Virginia. Louisiana may also, but I can't confirm that. They are on the subscription model. Only one of those states, which is North Dakota, has retained prior authorization requirements for treatment at all. So just a side note, there are 28 states and 1 U.S. territory that have removed prior authorization requirements for DAAs for simplified treatment from their Medicaid program. The last point I'd like to make is dispensing the full course of therapy is effective in curing hepatitis C. It's safe and it overcomes many patient barriers that both our healthcare professionals and our individuals who are afflicted with hepatitis C face. There is a minimal monitoring approach, the MinMon approach, and it has been published and shown that DAAs dispensed in a full course of treatment retain high cure rates with very mild side effects and none severe. So dispensing that full course at once helps overcome the barriers that lead to lapse in medication between fills, not obtaining refills, resulting in missed dose and reduced treatment effectiveness. We know that many of the barriers that our individuals suffer from that have hepatitis C are transient living. They have transportation issues. They have financial burden. They cannot access their pharmacy in a timely manner, either because they cannot travel to it or they can't reach the pharmacy. Many of them have burner phones. So we can circumvent the one thing that we can control is how much medication they get when we have them available. Trying to follow one of these patients is like trying to follow a ball that is, bounced in high weeds. You see where it starts, but you don't see where it necessarily ends. But if they have that medication with them, there's a higher likelihood that they will be able to complete their therapy. And lastly, I think that this could also address the hepatitis C in our incarcerated population, particularly on reentry into society with the 1115 waiver, which I know many here have worked very hard on. So that's it in a nutshell. If you have any questions, I'm happy to try to answer any, but I advocate for this. Typically, I would say, we need to speak to a pharmacist frequently. We need to increase adherence. This is just a unique patient population, a unique disease, and low rate for failure and very safe in a studied approach where the full course of therapy is dispensed at once. And, I kind of equate this to treating a bacterial infection. We give the full course of medication to patients and tell them to make sure they take it all. We don't dispense half of it and tell them to come back later when they feel a little bit better. It just seems intuitive to me to do this.
I've got some, oh, go ahead.
No, go ahead, Phil.
I was going to add, appreciate your comments. The CDC came out with an article in 2016, and they said that this is pre-COVID, but hepatitis C kills more Americans than any other infectious disease. And I think a lot of us don't think of that right off the bat, but that's how deadly it is. And Kentucky has got a tremendous burden of this disease. University of Kentucky, we started a screening program in our ED in 2018, and since then we have screened over 212,000 patients. 2023, we invested in putting 5 pharmacists full-time in the ED with FibroScans. They got trained on FibroScanning technology to find a way to get these patients faster to treatment. Per Jill's comments, they're like blips on the radar sometimes, because this is a syndemic disease. It's paired with substance abuse. And when they show up on the radar, you want to be able to meet that patient where they are and get them treatment. Having to do 3 separate monthly fills is a barrier to curing these patients. I would say the University of Kentucky, we submitted a request to DMS and MedImpact in 2023, October 2023, to extend this to 84 days. And they said that both teams at MedImpact and DMS spent time analyzing, discussing, and reviewing the request. However, after completion of the analysis, they determined that the request to the changes would not be made. That same year, there was an open comment from November 9th to December 9th, 2023 regarding the 1115 waiver. And the University of Kentucky also submitted a request for incarcerated individuals to allow the 84-day dispense, because there is a lot of disease burden in our incarcerated population. And and being able to treat them before they're released would be great. Having that 84-day potential would open the doors to really helping us overcome this disease burden in our state. So needless to say, from my perspective, I'm overly supportive of the 84-day dispense.
And Jill, this is Ron. Of the 6 or 7 states that you referenced that allowed the full therapy to be dispensed, do they have any statistics yet on the lowering of the transmission rates or just lowering of diagnosis rates or any of that?
Ron, I looked through every state's DUR meeting minutes. Unfortunately, I wasn't able to pull that information out from what's publicly available. I imagine that reaching out to those individual states, you might be able to get that information. I know for one state, they definitely reviewed it, but what they decided upon was not provided. They did change their day supply dispense to the full course of therapy after that meeting, but I don't know what or if there was any information from that review that made them, that triggered that change. Virginia has a really nice model, I would say, if PTAC were to be interested in changing to that full dispense supply, that would mirror, I think, what Kentucky would do. There is one state that mandates it. You do not have the option to do an 84 or 56 day supply. You have to, a 28-day supply. You have to do the full course of therapy, and there's no splitting it to
State is
monthly.
that, Jill? Do you mind me asking?
Sorry,
What state is that? You said there
that's
was
North Dakota.
Okay.
They also, I believe, hang on, I will double check that now that you've asked me. I have a table. Yeah, it's North Dakota. And North Dakota is also the only state that still retains that prior authorization of the states that are doing the full course supply in one fill.
Thank you. Great information.
You're welcome. Happy to share. There's
Any-
also a congressional budget report that came out last year, which is probably old news, but in the event that you've not seen it, they published in, I believe it was June of last year, the CBO published their analysis of what effect policy would have if Medicaid increased their hepatitis C treatment. And I would take a read on that. I think the takeaway is that they estimate that 100% increase in Medicaid enrollees treated for hepatitis C would reduce federal spending on healthcare by $7 billion over 10 years. And they used two states, I think Michigan and Louisiana, looking at their treatment rates to come up with their model. So.
To comment on that, I think we did an analysis, we saw some literature, the estimated cost for Medicaid to cover the cost of medication, say it's roughly $20,000. The cost of liver disease and disease burden downstream from cirrhosis and whatnot is estimated to be around $210,000. So we estimate about $190,000 savings per patient that is successfully treated and cured for Hep C.
Wow. Okay, do I, first of all, have any further discussion? Okay. Do I have a form of a motion to make that would ask for Kentucky Department of Medicaid Service to reconsider this policy?
I make a motion.
Okay, that's Rosemary makes the first motion, second by, is that Paula?
Yes. A
Okay.
second.
Any further discussion? All those in favor say aye.
Aye.
Okay.
And any opposed? Okay, motion passes. And again, Kelly, I'll get you a summary of everything.
Thank you.
I will say that, we have been evaluating the day supply requests. And we've been speaking to some folks over at Department of Public Health and the Hep C Coalition group. The one thing that we're doing is pulling some new adherence data to see, what percent of members are adherent to therapy, their full 84-day course. And are receiving those medications. I understand that, some of it might be some individuals, the transient individuals that Jill mentioned, who are either going from place to place or don't have a steady place to live, might be might not be completing their course of therapy. So, all of that is under our review, to take back and discuss. So, we should have some updates by next month.
Okay. And Jill, do you mind sharing your research?
I'll be happy to, Ron. Chairman Poole, where would you like for me to send
Well,
that to Aaron?
I was gonna just have you send it to Fatima, and if you don't have her information, you can send it to me and I can get it to her.
Okay, I'll send it to both of you, and thank you to the committee and Dr. Ollie as well. Appreciate the consideration.
Okay, thank you. Okay. Since this is a regular meeting, somebody else, if you've got another new business item or anything, discussion, the floor is open. Anybody have anything? Okay. And I'll be filling in the recommendations and motions for Kelly. I'll get that to him. The next PTAC meeting is April the 9th. Just to give you the rundown on the rest of them for the rest of the year, which I tried to send out earlier, but April 9th, June 11th, August 13th, October the 8th, and December 10th. Okay. If we have nothing else to go before our PTAC, do I have a motion to adjourn?
Motion to adjourn.
Second.
Okay. First by Meredith, second by Philip. Any further discussion? All those in favor say aye.
Aye.
Thank you. Or any opposed? Thank you, everyone, for your participation today. Really appreciate it.
I guess.
Thanks.